that we're going to follow as we go through this talk. Overall, the general treatments for stress incontinence, as everyone knows, are observation, pelvic floor physical therapy, plus minus oral medication. Duloxetine is sometimes considered an oral medication for stress incontinence. Injectable therapy, which is a separate distinguishable column here from surgery. We're specifically focusing on surgery. And then in terms of all of the surgical treatments for stress incontinence that have been considered since the AUA started looking at this and coming up with guidelines panels, those in red are the ones that we can offer patients. So the Birch retropubic urethropexy, sometimes called a copal suspension, an autologous fascia pubovaginal sling, and then the mid-urethral slings, retropubic transobturator, and in the most recent iteration, we can now offer single incision slings with much less data than the retropubic and transobturator slings. So going to the early part of the last century, most of the techniques involved placing some sort of muscle around the urethra. So the von Giordano involved transferring the distal end of the gracilis muscle and wrapping that around the urethra. The Goebel procedure used a sling of pyramidalis sutured around the urethra. And then moving on, the Fragenheim involved using a sling of pyramidalis and then also some of the overlying rectus fascia being incorporated into the sling. And then finally, the Stoeckel technique added plication of the muscular structures around the bladder neck as a treatment for stress incontinence. And the common belief at that time is that if you put some muscle around the bladder neck, it would acquire a sphincter-like function and allow things to stay closed. Moving on, all of those procedures had all of the imagined complications you would associate with them. And so further improvements were all aimed at trying to be more efficacious with less morbidity. And that's certainly been the theme throughout the last century. So the Price sling involved passing fascia lata beneath the urethra from a suprapubic approach. So that's sort of closer to what we recognize today as a precursor to the fascial sling. The Aldridge approach used bilateral strips of rectus fascia without the muscle this time, passed through the retropubic space, and then those ends were sutured under the urethra. And then finally, the Palm-Rich in 1962 sling was from the inguinal aponeurosis of the external obliques. It was left attached to the pubic tubercle and then sutured under the proximal urethra. So muscle's gone out, and now we're using mostly just a connective tissue as our sling. And then finally, in 1962, the first synthetic sling was introduced. Slings fell out of favor because they had a lot of complications associated with them. Urethrovaginal fistulas, urethral sloughing, losing the entire urethra because it was devascularized. Certainly outlet obstruction, the development of retropubic abscesses, and these were then generally reserved for the most challenging patients. So new techniques were all, again, looking at trying to improve continence, looking at perhaps different physiologic theories of incontinence, or of continence, and minimizing morbidity. So some of the theories of and treatments of urinary incontinence include the reason women leak is hypermobility of the bladder neck and the proximal urethra. And the treatments that can address that are the retropubic urethropexy and the pubovaginal sling. Intrinsic sphincter deficiency, really, which has the pubovaginal sling as the main treatment option. And then loss of mid-urethral integrity, which is the theory that mid-urethral slings are based on. And we'll talk about those. All of these are proposed contributors to continence, so intrinsic and extrinsic factors. The mucosal seal itself, having a healthy submucosal plexus, having the bladder neck be competent, the intrapelvic position of the bladder neck, so no prolapse, and the hammock-like support beneath the urethra. The intrapelvic position of the bladder neck is what we're looking at, is the idea we're looking at here. So if this is your pelvic floor, this is your bladder, this is your urethra. When the bladder descends in this position here, if all of this stays above the pelvic floor, then the proximal urethra is compressed kind of against the pubic symphysis there. With descent here, the proximal urethra isn't compressible against that pubic symphysis, and leakage can occur. So the retropubic urethropexies, the idea behind them was to restore the intrapelvic position of the bladder neck. So this was the retropubic urethropexy. Some of the needle suspensions that we'll talk about were designed to mimic that, but with less morbidity. And in old operative notes, you can see, we restored the bladder neck and the proximal urethra to a high retropubic position. So just comparing these retropubic urethropexy, again, sometimes called copal suspensions, these were done typically through a lower abdominal fan and steel incision, and the operating surgeon would be operating from above and also have fingers in the vagina, pushing up on the tissue around the urethra to identify the proximal urethra and bladder neck. The vaginal finger aids in exposure of what was called the periurethral fascia of the vaginal wall. The proximal suture is placed slightly proximal to the bladder neck. The distal suture is placed 2 centimeters lateral to the proximal 1/3 of the urethra. And the way that these two procedures differ, the Birch and the Marshall-Marchetti-Kantz procedure, is how they're attached. So the Birch is attached to Cooper's ligament over here, whereas the MMK is attached to the periosteum of the pubic symphysis. And the other way that they're different is that the Birch is tied loosely. So it's typically described as 2 finger breadths that you can fit under the suture, whereas the MMK directly opposes that tissue to the periosteum of the pubic symphysis. Because this is sometimes an off-site question, suture placement is most likely to injure the obturator nerve or entrap the ilioinguinal nerve with these surgeries. Voiding dysfunction is a potential complication with all anti-incontinence procedures, and this is one of those, anywhere from about 1.7 to 25%. Both the Birch and the MMK can be complicated by postoperative cystocele and enterocele, less than 20% of the time, and you can kind of see why that is. You're yanking up on this tissue, and the anterior bladder wall behind that becomes a little more prominent. And then the MMK in particular has a 1 to 5% incidence of osteitis pubis. And I'm just going to talk about that briefly because, again, that used to be on testing. I don't know if it still is. Osteitis pubis is different than osteomyelitis. It's self-limiting, it's not infectious, and it's an inflammation of the bone, whereas osteomyelitis is a progressive pyogenic infection. But these two things can really present very similarly, typically with pain, difficulty walking, a wide gait. These patients can have fever, even if it's a non-infectious etiology. They can have a high white count, they can have an elevated SED rate, and really it's radiographic imaging that allows you to discern between bone destruction with osteomyelitis and no bone destruction with osteitis pubis. Osteitis pubis is treated with anti-inflammatories and steroids, osteomyelitis obviously with IV antibiotics. So the Birch procedure has good long-term results. This study is small, but one of the early ones. 44 patients who were followed for 8.5 years. 78% of patients were cured of their stress incontinence, 12% significantly improved. An earlier study looked at patients all the way out to 20 years and noted that after about 12 years, the long-term cure rate plateaued at about 70%. De novo detrusor instability, about 15%, long-term complaints of voiding dysfunction, 22%, and recurrent UTIs in about 4.6%. So now we have reasonable data to suggest that the open Birch has good long-term 5-year results. That's something we can offer our patients with reasonable data and reasonable follow-up as an option for stress urinary incontinence treatment. Moving on a little bit to the bladder neck suspension. There's not very many people in this room. Anybody who knows who this is can holler it out. Dr. Nakata. That's Tom Stamey. Tom Stamey was the former chair of urology of the Division of Urology at Stanford, and really a former Hugh Hampton Young Award winner, and I think almost also a Raymond Gutierrez Award winner. He had his finger in a lot of different fields of urology, including prostatitis, renovascular surgery, as well as urinary incontinence surgery. And he invented PSA density testing. Anybody know who this is? Anybody other than Dr. Nakata? Yes, way to go. Thank you, Dr. Das. This is Shlomo Raz. He was he's recently retired since about 2020, guru of female urology at UCLA for many, many years, and he has his name on a number of procedures and a number of innovations in our field. So the needle suspensions. The Pereira needle suspension introduced in 1959, the STAMI in 1973, and the ROS in 1979. And all of these involved trying to find a less invasive way of hiking up that tissue around the urethra. So the Pereira suspension, that's a Pereira needle at the top here, postulated that by suspending the periurethral tissue to the rectus fascia, you could create basically some outlet obstruction, and patients would not then leak. The STAMI procedure introduced the use of cystoscopy to determine how tight your suture should be. It also incorporated a Dacron graft as a bolster, and I'll show you a picture of that. And then the ROS procedure involved these helical suspensory sutures. This is a STAMI needle. We still use the STAMI needle for autologous fascial slings sometimes, and other procedures where we have to pass things behind the pubic symphysis. So this is an old drawing because it's the only one I could find of a STAMI bladder neck suspension. So the procedure is both a suprapubic and a transvaginal approach. You're making an incision near the bladder neck here, passing the needle down to grasp some suture material, and then passing that suture material from some bolster. The bolster was thought to help keep the suture from just ripping through the tissue. Bolsters can sometimes still be found in bladders many, many years later. So this is that suture going through a Dacron bolster. This was found about 19 years after the original surgery. This is one that we found in a bladder when I was a fellow. You can see the stitch here and then the vascular graft there. This is a patient who presented with recurrent UTIs. This is when we took it out. So those procedures had some issues, had some problems, and this led to revisiting the pubovaginal sling in the 80s and 90s. The hammock hypothesis of stress incontinence is that the urethra lies on a supportive layer, which is composed of endopelvic fascia and the anterior vaginal wall. John Delancey is an OBGYN still in practice at the University of Michigan, who's contributed an enormous amount to our field, particularly being one of the people who helped introduce the TVT. So in the hammock hypothesis, the anterior vaginal wall and pelvic fascia act as a hammock, which compresses the urethra during increases in intra-abdominal pressure. When that hammock is gone, the increases in pressure lead to urine getting into the proximal urethra. Oh, I thought that was going to do something else. Sorry. Lead to urine getting into the proximal urethra, which leads to incontinence. So the classic original McGuire sling involved only semi-detachment of the rectus fascia. So it was still attached at both ends here, passing that rectus fascia down through the endopelvic fascia, and then the free end was attached to the rectus fascia. The Blavis modification, which is really what we do today, involved the complete detachment of the rectus fascia, penetrating, making sure that the sling, portion of the sling penetrated the rectus endopelvic fascia, and the ends were tied over rectus loosely. And this is a picture of our current fascial sling. Autologous fascial slings have similar complication rates to the Birch urethropexy, retropubic urethropexy, so urge incontinence and difficulty voiding being the two main ones. But multiple authors reported a 75 to 85% cure rate with greater than 5 years of follow-up. There was no associated pain with intercourse with this type of sling as long as bone anchors weren't used. We aren't talking about bone anchored slings because we hardly ever see them anymore. A 5 to 50% rate of voiding dysfunction, and this too was considered a gold standard sling. Anybody know who this is? Dr. Nakata. Yes, Dr. Blavis. Dr. Blavis is also still in practice. He's been at Columbia, I believe, his entire career, or the majority of his career. Is that right? Cornell, I'm sorry, Cornell. And again, one of the gurus of female urology. This is his data. He followed a number of patients out up to 12 years, and then some patients out up to longer than that, and had great follow-up for stress urinary incontinence. So now we have those two procedures that we can use. We can use a Birch, we can use a fascial sling. And that's right around the time that the first guidelines panel came out for stress urinary incontinence. And at that time, the surgeries that they looked at included retropubic urethropexies, transvaginal bladder neck suspensions, anterior repairs, which is a Kelly plication, so basically tightening the tissue under the bladder neck through a transvaginal approach, and then pubovaginal slings. And I think this is sort of the graphic that changed a lot of things. In that meta-analysis, what we found was a significant benefit in terms of cure dry rate at 48 months to the retropubic slings, retropubic urethropexies and pubovaginal slings as compared to the bladder neck suspensions and anterior repairs. And this is just to show how much guidelines can change practice. So a team looked at what the majority of urologists were doing in 1996. 71% were doing needle suspensions, 25% doing retropubic suspensions. 5 years later, that had changed to only 38% doing needle suspensions, 16% doing retropubic urethropexies, and a significant increase in the number of pubovaginal slings being done. And that is what prompted the Urinary Incontinence Treatment Network to start the sister trial, which recruited patients from about 2002 to 2006. And this was a study to look at, well, hey, we know that Birches are really good. We know that fascial slings are really good. Which one's better? Which one should we be offering patients? So this was a multi-center, randomized, controlled, randomized prospective trial comparing the Birch to an autologous fascial sling in patients with pure stress incontinence. 665 patients were recruited, 80% or so completed the study, and the results were assessed at 24 months. And these were the success rates. So the sling was about 66%, and the Birch 49%. So not fantastic, and we'll talk about why that is in just a second. And then one of the main things that they determined was that significantly more women who had a sling had voiding dysfunction and UTIs, and retreatment was higher in the Birch group. So again, looking at the sling procedure makes you more continent, but at the expense of more complications. It was can I make this go away? Yes. The sling procedure that had, was the only group that had any voiding dysfunction that required surgical revision. None of that was seen in the Birch group. One of the reasons that has been postulated that the success rates are so low is that the primary and secondary outcome measures were incredibly strict. So it was a composite measure of overall incontinence. You had to have no self-reported stress incontinence. You had to have less than 15-gram increase in your pad weight, no incontinence on a 3-day diary, a negative cough stress test in the office, and not require any retreatment. And that's a pretty strict measure of continence. And so again, sling 47%, Birch is 38% if you do an overall incontinence success rate, including the primary and secondary outcomes. So the sister trial, serious adverse event were not statistically different between the two. The surgical procedures to reduce voiding symptoms or improve retention were performed only in the sling group, and the time to return to normal voiding was a bit longer in the sling group. So the conclusions were that the pubovaginal sling has a higher efficacy than the Birch, but the success comes at the cost of more complications, and that clinicians should discuss these trade-offs when they're talking to their patients about the procedure, and that also when we're talking to patients about treatment for stress incontinence, we need to talk about the fact that being completely dry is likely an unachievable goal in all about except 1 out of 4 patients. We can make you better. We probably aren't going to make you completely dry. They did then publish in 2010 the extended sister trial, so looking at improvement over a 5-year rate, and it does, the point of that is it does continue to decline. The continence rates continue to decline at the 5-year rates. So then the integral theory. This is that continence is dependent on fixation of the mid-urethra at the pubic bone, and that there's a physiologic backboard, and the mid-urethra should be supported by that backboard, but not elevated or obstructed. So that's the theory behind the tension-free vaginal tape. It also is that the continence is dependent upon support of stretch receptors at the proximal urethra. So if that backboard is lax, there's going to be dissipation of muscle contraction that leads to stress urinary incontinence, and stimulation of stretch receptors at the bladder base, which can lead to urge urinary incontinence. So the TVT was introduced in 1996 in the United States and involved placing a type 1 polypropylene mesh loosely at the mid-urethra. So the idea is that the sling is only engaged during Valsalva maneuvers. It's not constantly providing upward traction against the urethra. And this kind of cool study from 2003 looked at 40 patients. They had perineal ultrasound before and after a TVT at rest and with Valsalva. And they were able to show that the tape rotates towards the symphysis. The bladder neck really is unaffected in this because we are putting it at the mid-urethra. There is dynamic kinking during stress that isn't there when they're not coughing. And there is compression of the urethra between the sling and the symphysis during stress maneuvers. So function is dependent on that hypermobile urethra, on some movement of the urethra with coughing, laughing, jumping, bending. This is just to point out that in the early studies, excuse me, none of which were huge and all had fairly short-term follow-up, success rate was good. Dr. Nielsen, who published one of the early studies with his group of 90 patients that he followed prospectively out to 17 years, published his 11.5-year results in 2008. Again, this is a single surgeon study, but 80% of the original 90 were evaluated with a cough stress test, a PAD test, incontinence questionnaires, global impression of improvement. And the objective cure rate was 90%. The subjective cure rate was about 70% cured, another 20% improved. So no distinct decline in the cure rates over the 11 years in that study. No adverse effects at 11.5 years with mesh material in that study. And he concluded that tape erosion did not occur. Sorry, that's going to be slow. He then published in 2013 the 17-year results. There were still 58 women that he could follow from that original cohort. Success rates remained high, but there was, I believe, one mesh extrusion in the right periurethral area at 17 years. So now we've got TVTs. They're much less invasive. They seem to be pretty effective. How do they compare to the open Birch, which we said, to an open Birch procedure? How do they compare to our other gold standard slings? So Ward and Hilton did the seminal study on that. This was a prospective randomized 14-center study in Ireland and the UK. 344 patients were collected over a 15-month period, comparing TVT to an open Birch. And the objective cure rate was similar between the two. TVT remained comparable with copal suspension at 24 months, and there were some economic considerations. So the TVT is a lot less expensive because it's much shorter of a procedure to perform. There's less anesthesia, less OR time, no recovery room time, less hospital stay, less blood loss, et cetera. They then evaluated that same cohort at 5 years, and the cure rate remained similarly, not statistically significantly different. There was an increase in enterocele and rectocele in the Birch group, as we talked about, and there were 3 late tape complications in the TVT group. So now we have these 3 things that have good 5-year outcomes. But many urethral slings have their own set of issues. Some which are not unique to mesh slings. De novo urgency is not unique. Urinary retention is not unique. But vaginal mesh extrusion, which is what we're seeing here in the top picture, urinary tract erosion, so the mesh working its way into the bladder, or urethra over time. Visceral and neurologic injury is a possibility with any time we're passing things blindly, right, and then bleeding. The initial data, this is all doctor-reported questionnaires, demonstrated a fairly low rate of complications, but the meta-analysis showed something probably a more reliable picture of what was actually occurring. So intraoperative complications included bladder perforations at a rate of anywhere from about 6 to 10%. There is hemorrhage, not necessarily requiring transfusion, but greater than 500 mLs and about 2.5%. And then those folks have hematomas. Sometimes patients are in retention, and about 5% go on to needing some sort of reoperative procedure. De novo urgency occurs at about 15%, which is about the same as for the other procedures. And then intravaginal tape erosion about 0.5%. Just to show you, why does vascular injury occur? This was a nice picture showing a TVT, a bottom-up approach TVT. And really what they're showing is that, fairly minimal movement of your vaginal sided hand, left or right, can lead to significant derangements of where it's exiting up above. And there's lots of vessels in that area. So in this picture, this is the bladder with contrast, and this is a big pelvic hematoma, which I'm sure happens much more than we capture. So the retropubic space, so the point of that is that the retropubic space can be scary, which is why the spark was introduced. This was the first bottom-down mesh midurethral sling. And the idea behind that was, one, urologists were much more comfortable passing things from here to here, because that's what we did for bladder neck suspensions for most of the 80s. and that you might have a more controlled method of passage in this area and avoid the bowel and vascular injury that we were seeing with the TVTs. The first study to compare TVT to Spark was completed in 2006 and essentially showed that actually the Spark was not equivalent, close, but not equivalent. Subsequent studies have showed no real difference between the two approaches. Then the Transobturator sling was introduced because maybe the issue isn't top down or bottom up. It's just we need to stay out of the retropubic space altogether. So how can we do that? So that's why the Transobturator approach was introduced. So with this type of sling, this is showing an inside-out Transobturator sling. Instead of passing the sling around the pubic symphysis, it's passed around the ischiopubic ramus and exits through the obturator membrane there. So it's going to preserve the midurethral position of the mesh, but avoid the retropubic space. And we're avoiding all this scary stuff over here by hugging the bone and coming out about 2.5 centimeters away from that. And then, because there were nerve injuries associated with Transobturator slings that we'll talk about, the single incision slings were introduced. So this avoided blind trocar passage altogether, the thought that we would have similar efficacy with less complications. And there's less mesh in total, so maybe less complications because of that. The TVT Secure was the most studied originally. It was taken off the market in 2009, I believe. This is a picture of one I took out of a bladder. The mini arc sling was a competing product. It attached slightly differently. This is a picture of one that Dr. Best helped me take out of a bladder. And this is a study that I did with one of the former residents here, looking at do single incision slings really have lower complications? And the short answer is no, not really. And when the FDA reclassified mesh, what Dr. Pennycuff was talking about last week, as a class 3 device, they basically said, we need to study transvaginal mesh for prolapse a lot more. We don't need to restudy transvaginal mesh for stress urinary incontinence, except for single incision slings, which don't have the same data as the retropubic or midurethral approaches. So the single incision slings were not included in our AUA guidelines until the most recent iteration. This 2023 Cochrane review says that we can offer single incision slings to patients, but that we still need to consider the fact that the data is not nearly as mature. The TOMUS trial was, I believe, the last study of the urinary incontinence treatment network. And this was, now that we have the retropubic approach and we've got the Transobturator approach, which one's better? Or are they at least equivalent? And that's what this study, this was an equivalence trial comparing retropubic and Transobturator slings. The treatment success was evaluated at 12 months, pretty strict criteria for success. And there was the predetermined equivalence margin. 597 women were randomized. And success rates were essentially equivalent. So the Transobturator was considered non-inferior to the retropubic sling. There were different complications. So in the retropubic group, more voiding dysfunction requiring surgery. The way I imagine that is because it is a more obstructive sling simply because of the way it lies. And in the Transobturator group, there are more neurologic symptoms. So the grade 3 and 4 complications, bladder perforation occurring solely in the retropubic sling group, and then voiding dysfunction requiring surgery occurring more and solely in the voiding dysfunction in the retropubic group, and then neurologic symptoms occurring much more often in the Transobturator group. In terms of patient satisfaction, patients were really satisfied with these, 85% with the retropubic and 90% with the Transobturator. And then no significant differences between the groups, between baseline, postoperative distress, bother, or quality of life scores. So conclusions was that they could be offered equally and that the differences in complications across the two procedures should be discussed with the patients. The 5-year longitudinal follow-up of TOMUS showed that there were 7 new mesh exposures in years 3 to 5 following the surgery. So that's something that is a risk across a lifetime. And the total rate of mesh exposures was still only about 1.7%. And the other thing that was interesting is that treatment success declines with time. The thought of introducing mesh as opposed to fascia is that perhaps this would be a more long-term solution. And again, that original data set of the guy who followed his own patients for 17 years really didn't show a decline over time. In a more objective study, we do definitely see a decline in over time of this type of surgery. So that's what that's about. The 2009 AUA guidelines reviewed 7,000 articles, but only at that point, because mid-urethral slings were introduced in 1996, uptake was in the early 2000s, only 80 patients with mid-urethral slings were included, who had long-term follow-up, were included in those guidelines. So at that point, they reconfirmed the efficacy of an open retropubic urethropexy to the sling. And they were able to state that synthetic slings at the bladder neck have a higher complication rate than fascial slings, and that these complications are not seen when the mesh is at the mid-urethra. But they couldn't really comment on mid-urethral slings as an option, as a long-term validated option. So we'll pop through here. 2017, we actually did have an enormous amount of data on mesh mid-urethral slings. And by that point, the index patient could be offered a mid-urethral sling synthetic, autologous fascia sling, a Birch copal suspension, or bulking agents. And then just last year, the 2023 guidelines came out. And really the main difference there is that single incision slings are added. And then there's some consideration of special cases, the fixed immobile urethra, if you're doing surgery with prolapse at the same time, patients with lower urinary tract symptoms or neurogenic lower urinary tract disorder, and then patients who have other factors. So how do I choose? Are we close? Yeah, we're good. A retropubic mid-urethral sling is a great option for a healthy woman who's bothered by her stress incontinence. Ideally, you want to see some mobility of the urethra on an exam. That can just be visualizing it on a pelvic exam. You can see that on video urodynamics. You can do a Q-tip test, though I don't do that very often anymore, by putting a little Q-tip in the urethra and seeing how much it moves when they cough. They should have a lower post-void residual. It's fine if they need prolapse surgery, and you can do this regardless of whatever, at any sort of Valsalva leak point pressure. You can do this if they also have detrusor overactivity. You can probably do this whether or not they Valsalva void or not, though I would be a little worried if all of their voiding was by Valsalva. Transobturator mid-urethral sling in the United States, it's really any candidate for a retropubic mid-urethral sling is also a candidate for a transobturator. I certainly would think about it in those who have a high risk for a lot of retropubic scarring or multiple procedures in the suprapubic area, or the example I always give is someone who's had a fem-fem bypass, right? You don't want to pass needles blindly in that area. And then I like the surgery for patients who have a BMI of 45 or above. I think the landmarks are easier to find. In the UK, you cannot offer a transobturator sling at all, and we'll talk a little bit about that. An autologous sling, anybody who's also a candidate for a mesh sling is a candidate for an autologous sling. The outcomes are the same. Anybody who's at high risk for erosion, so that might be somebody who's on estrogen ablation therapy for breast cancer, somebody who's had prior pelvic radiation, certainly. Anybody with an immobile urethra, because remember the mesh slings shouldn't work as well for somebody with an immobile urethra. Someone with intrinsic sphincter deficiency, and then recurrent or reoperative stress incontinence surgery. And the Birch urethropexy, which most of you probably will not see in your tenure here, you could certainly consider for someone undergoing a simultaneous abdominal prolapse repair. It's easy to do a Birch at the same time if you're open. And any patient who has really limited vaginal access would be a candidate for a Birch. And then bulking agents. In 2020, this was really poor operative candidates or patients who'd had inadequate outcome from their first incontinence surgery. So the original pubovaginal sling data from McGuire included in the success rate patients who did well from their sling and patients who did well from their sling plus a bulking agent later. In 2024, all those same people, but also probably some patients who are just interested in a less invasive surgical option and are willing to accept that need for repeat injections. That's what's really highlighted in the guidelines. What are we going to think about next? Still, stem cell therapy for incontinence has been something we've thought about for a long time. There's lots of study on it, but not a lot of uptake. Delancey's next target is looking at the mechanism of urethral closure. So improving our understanding of factors affecting urethral closure may lead to novel treatments targeting the urethra and improved understanding of the small but persistent failure rate of the current surgeries. Because he has noted that there's a gradual decline of maximal urethral closure pressure by decade. That's about 15%. When I gave this talk last in 2020, there was, a lot of concern in my field that midurethral slings were going to be banned in the United States. And then the new guidelines talk about better patient education and counseling. And just to spend a minute on that, because I think we can't talk about mesh slings without talking a little bit about the mesh controversy. This graphic is busy, but what it's showing is this is 1997 to 98, and then yearly to 2013 to 2014. And it's showing procedures that were done in the UK for stress incontinence. So almost all open cupal suspensions in the latter part of the 90s, early 2000s, really quickly becoming mesh slings from about 2006 onward. And there's a lot of backlash against slings, or about mesh, partially because the success of the mesh slings led to the introduction of the mesh kit repairs for prolapse. And the mesh kit repairs for prolapse have at least a 10% complication rate associated with them, but they are very different procedures that all got lumped in together. I'm just showing some of the websites. Last time I gave this talk, this was like 1 million and something website hits and counting. And now it's 2.3 website hits and counting. This is another, Sling the Mesh is another big group that is very anti-mesh and very vocal. And this very anti-mesh and very vocal group led to, in the UK, the highly vigilant pause. So in 2018, the National Health Service wrote to all acute trusts, advising of the immediate implementation of a high vigilance restriction regarding vaginal mesh. So you could offer a Birch, you could offer an autologous rectus fascial sling, but you could not offer mesh slings during this pause, which lasted about a year. If you were going to use something with mesh, it had to be done with an expert healthcare professional and only be performed by patients or by physicians who have expertise. Ultimately, the NICE guidelines allowed physicians in the UK to offer retropubic mesh slings, but not Transobturator, but with a very significant patient counseling component to it. So discussion with the woman had to include the benefits and risks, of course, and offer the patient to go to somewhere else if they didn't have a surgeon who was considered, who was certified to do this locally. They had to talk about the uncertainties and the long-term adverse effects from the procedures, the differences between the different types of procedures and what to experience during surgery, and then any social or psychological factors that can affect the woman's decision. And ultimately, you can offer a Birch, a fascial sling, or a retropubic sling, and then there's specific guidelines about who can and cannot perform a mesh midurethral sling. They did come, and then they also created at the same time mesh multidisciplinary teams. So if you are someone who has a mesh complication in the UK, you can only go to certain sites that have teams that include this really extensive group of people, urologists, urogynecologists, radiologists, GI doctors, potentially a neurologist, a plastic surgeon, et cetera, who are certified in removing mesh. And they came up with a beautiful, actually, surgery for stress incontinence patient decision aid. It's long, it's about 23 pages long, but written nicely at the patient level with graphics, like up here in the corner. You've tried lifestyle changes, you've tried pelvic floor muscle training for at least 3 months, because in the UK, you have to do pelvic floor physical therapy before moving on to surgery. And you're here, you're thinking about surgery. So these are the things that we can talk about. It gives graphic descriptions of what risk look like, so patients have a better idea of and can visualize what you're talking about. It introduces the idea of bulking agents, and then comes up with this nice thing that patients can fill out at the end, where they can rank their competing priorities and decide on a surgery. So really nicely involving patients in their surgery. And I wanted to talk about that because that is from the 2023 updated guidelines. One of the things that's highlighted is that we need to do a little bit better job of educating our patients and paying attention to their level of health literacy when we do that. And that's the end of my talk. Thank you for your attention. Any questions?
Questions for Dr. McAchran?
I'm happy to answer.
Start with Dr.
Yeah, well done. In light of any content-related questions, so I had a harder question for you, Sarah, but I think it's reasonable. You know, in light of ERPS, you know, and its certification, you know, how do you feel now about it, you know, down the road and its relevance, you know, with regards to non-accredited urology fellowships in female? You know, what is it? What is ERPS or FPMRS? What's the impact been on the field?
So I think your question is, so we are subspecialty board certification as of 2013. And do I think that has been, how do I think that has benefited our field? I think it has, I certainly think in the area of, because we just talked about it recently, mesh controversy, it has allowed specialists to perform these procedures and kept non-specialists from performing them. And that is a benefit to patients. I think that the collaboration with urogynecology benefits patients in the end, because we ultimately do bring different things to this field. I think it's an incredibly important field for urology to continue to perform in. And I think that subspecialty certification, I don't know that it necessarily has to be through the joint board, allows urologists to stay in that space, because OBGYN will definitely continue to be in that space.
I had a little bit more maybe of a technical question. You sort of left the bulking agents.
I did.
Kind of cut it a little bit, which there's a lot to cover, and I think it's probably a minority of what is done. But
Yeah.
Is there anything? Back when I trained, it was collagen, which I think is no longer an option. But what are we using currently?
Yeah.
You know, is there anything exciting coming down the pike? I agree, the stem cell thing, you know, maybe hasn't really panned out, but where are we at with
Yeah.
that?
So the history of bulking agents, right? I did leave that out because it's kind of considered not as surgery, but more a procedure for stress incontinence. But the agents that have been available, originally collagen. Collagen was had advantages of if you had a bad outcome from it, it went away at some point. So your body broke it down. Disadvantages of it had to be repeated. Some patients were allergic, so you also had to do some allergy testing for it. But it was taken off the market in probably around 2010-ish. In an attempt to have a more long-lasting bulking agent, multiple other ones were introduced, but the two that gained the most ground were coaptite, which is a calcium-based. You guys do that in your, we have Boston Scientific offers that in our simulation lab, and the macroplastique, which is silicone-based. These have the advantage of, for the most part, being able to be done in the office with varying levels of patient comfort. And the idea was that they would hopefully last longer, be more of a one-stop injection or two-stop injection than the collagen, which needed to be repeated over and over time. They don't work particularly well. They don't last very long. You're going to need repeat treatment at some point. You could quote maybe a 33% dry rate to patients, and a fair number, if you practice in this field long enough, you're going to see a fair number of complications with them eroding through the wall of the urethra or into the bladder, becoming calcified. And that's a really hard problem to treat. So I didn't end up doing very much of it because I felt like the risk-benefit ratio wasn't appropriate. Bulkamid is what we do primarily now. And the way that's different, we've talked about this recently, but the way that's different from other bulking agents is it's primarily water with about 2% of a particulate, whereas the rest were primarily particulate. The thought behind that is you don't get the intense inflammatory reaction that you get with some of the other bulking agents. And so and that is what should allow it to stay effective over the longer period of time. So it does have better long-term efficacy in reasonable studies. It is not as effective as a sling if you're just looking for cure. It is a better patient experience. So patients, right, in and out, sometimes in an office or in the operating room, but you can go back to your normal activity the same, almost the same day, certainly by after the weekend. And seems like it's going to be lasting longer. We have good like 3 and maybe 7-year data on it. Still don't have 25-year data on it though. So that's where bulking agents are.
Thanks, Sarah. Any other questions for Dr. McAchran? Dr. Das from the back.
Could you offer them bulking agents and then vice versa if they have residual after?
Yeah. I theoretically had concern if you've done macroplastic and coapatite and then you're putting mesh or fascia under that, particularly fascia though, are you then going to create, are you then creating pressure on this urethra that has this hard rock-like substance there, which then is going to lead to erosion. But that's a theoretical rather than, proven risk. Bulkamid should be less concerning for that. It's also injected far more superficially than you're not trying to get it into the submucosa. You're trying to get it just under the epithelium, not a little bit deeper. All right,
Well,
thank you.
thanks so much, Sarah. We'll take a few minutes and transition to the Journal Club.